Dr. Carlos Pedra from Brazil will present a case for maybe something slightly different. Carlos?
Thanks, Damien. Well, some of you might have seen this case before. We did that some time ago, but I decided to bring it back because we do have some follow-up results, so I think it was worthwhile presenting it again. So these are my disclosures. None is applicable in the context of this presentation. So this was a patient, in fact it was a fetus at 27, 28 weeks gestation with an estimated weight of 1 kilo. Mom was 35 years old on her second gestation. The first child was non-dysmorphic, and on ultrasound there were no signs of chromosomal abnormality. However, there was an associated malformation of pelvic renal dilatation. So these are the aspects of this left ventricle at this gestation age. This patient had critical AS with signs of impending hypoplastic left heart syndrome. So we're going to go over those signs. We taped that case, and we decided to go for a fetal aortic valvuloplasty, and that was done about 3 years ago. And so let's see what we get here. Should run.
One more picture. You see here the septum has a lot of fibroelastosis. Next. With the Doppler color, we can see here a jet of mitral MR, as you see here. And when we assess the LV outflow tract, you see here the aortic valve and a tiny jet of antegrade flow across the aortic valve. We measured the annulus, and it was about 4 millimeters. I had the same measurements yesterday. And here we are assessing the pulmonary valve and pulmonary artery, and here we can see here the ascending aorta, which has a very good size. It's very good on size, so there is no aortic hypoplasia. And here, when you look here, the flow across this is the ductus, so this is RV and this is ductus, and here, let it come back here, you can see the descending aorta, and here you see that the flow, it's retrograde at the transverse aortic arch. So this is one of the criteria to indicate the procedure. And just to show you the left to right shunt at the atrial level. So it's inverted shunt at the atrial level. Next.
Oh, stalled. Can you guys help me out with that? It's not moving.
Doppler tracing, as you see here, very short and tiny.
Can you show me the trick to do that with your wife when she's talking, that you can just fast forward it like that?
What is that?
Can you tell me how to do that trick with fast forwarding your wife when she's talking at you like that?
To select cases to do fetal aortic valvuloplasty. That's it.
So now you're drawing some blood for karyotyping.
Sem puxar minha mão, tá?
Fabio reached the umbilical cord, and we're drawing about 5 cc's. There is some heparin inside.
Pode tirar. Pode injetar um anestésico.
Now you're injecting some anesthetic. It's a mixture of fentanyl, atropine, and pancuronium for muscular paralysis. As you see on echo, you can see the fluid going into the umbilical cord. We have beautiful pictures here. So Fabio is holding the needle. This is a 20 gauge needle. It's about, it is 15 centimeters long. So now the baby has been anesthetized. Okay guys, let me show you the setup here we have on the table. First of all, we had forgotten to say that the patient, the mom, had been sedated with some midazolam, and she had vaginal blockage, right? So she's not feeling any pain, and she's sleeping soundly, so this is good. She's completely relaxed. We don't anesthetize mom, put under general anesthesia, because we want to change the baby position if need be, do an external version, right? The baby has to fight with the transducer, to fight with Fabio in order to achieve an optimal position, to get an optimal angle of attack, right? And now I'd like to show you the setup we have here on the table. As you know, the aortic valve annulus measured 4 millimeters. So we're gonna use a 3.5 millimeter balloon diameter by 1 centimeter long, right? And with pressure, this is a very compliant balloon. With 14 atmosphere, we reach 4.1 millimeters. So it's a little bit larger than the aortic valve annulus. And this is the recommendation to achieve complete dilation of the aortic valve, as we're going to see, hopefully. So we leave, this is a pre-mounted system, right? We pre-mount the balloon over the wire. We leave a little bit of wire out of the tip, about 3 to 5 centimeters. So the balloon is here, and we use some tapes to glue the wire with the balloon here. And this tape here marks the tip, the hub of the needle here. So doing that, I know that the balloon is going to be out of the tip of the needle, right? So when we see the wire in the ascending aorta, we just put up the balloon. We inflate the balloon here. So this is the setup. There's not much time to do all these things inside, so we leave everything ready to go. So Fabio is going to use 18 gauge needle. This is a Shiba needle. It's 15 centimeters long. Usually it serves all patients. You can reach your target with this distance. And this needle here, the same one that had been used for the fetal anesthesia, this is a 20 gauge needle. Sometimes we get some effusion after the procedure, especially because we have to take everything out at the end of the procedure. Otherwise, the balloon is sheared off by the tip of the needle. So we take everything out, and hopefully in this case we're not going to have any effusion. But if we do have, we can drain by sucking 1 to 2 millimeters of blood using this needle here. Right? We have here everything prepared. This is a natropine solution. This is an epinephrine solution. As soon as we get in, we're going to inject some epi in order to keep the heart rate ascending aorta. So the needle should be aligned with the axis of the ascending aorta. There was a little bit of tilt. Now the needle is going through the womb wall, placenta. And As soon as Fabio goes in, we're gonna inject some epi inside the heart to keep the heart rate within an acceptable range. Fabio is about to perk the apex of the left ventricle. He's almost there. Usually the left ventricle shrinks a little bit. Now Fabio's inside. Usually I tell him not to breathe, to hold. So I'm taking the stylet out. Blood is coming from the ventricle. I'm sucking some blood, injecting a mixture of adrenaline.
Carlos,
This is good. Now I'm gonna.
Yep.
what was the LV pressure?
Needle, Fabio. I'm just below the aortic valve.
Whatever it takes.
The pre-mounted system is here.
Now, some people do that with the pressure wire, by the way. This has been done, yeah.
I'm going with my wire inside the needle. I'm just pushing the catheter. Let's see if we can pass the valve. Pull back your needle a little bit. There. Yeah, we passed the valve with the wire. I rotated a little bit. Now I'm gonna push all the way towards the tape, reach the tip of the needle. You can pull back the needle just
Aumenta a
a
imagem, Simone.
Now I know we
Aumenta,
are in the
aí.
right spot,
Aí.
and Rodrigo is gonna inflate the balloon. Go ahead. Go to 14 atmospheres. There you go. Put it down. You just advance the needle a little bit, everything in, Fabio. Everything, there you go, there you go. That's a good spot. Go again, 14. Go again. 14. Put it down, down. The baby's doing fine, heart rate is good. There's no effusion. Usually we do that 3 times, right? With 14 atmospheres, we reach 4.2 millimeters. Remember, the annulus measured 4. Let's go again. Let's go again. Put up the balloon. Go again. Go again. There you go. One can see. Put it down. Put it down. Good. So now, as a unit, we're going to take everything out, but not now. Let's take our time for the balloon to deflate, so we can decrease the profile of the balloon. If I try to pull back the balloon within the needle, it's going to be ruptured, and we're going to have the balloon inside the heart. So that's not a good thing, right? So I think the balloon is down already. We can take everything out. Fabio is pulling everything out. We're seeing everything. There you go. The needle, everything is out. Now I have to pay attention if there's any effusion. If there is any effusion, we are ready to drain it. So it's good. The left ventricular function did improve a lot before our eyes. Right? There's no effusion.
You just wait.
There is forward flow, beautiful. You can see in blue. Remember, there was only retrograde flow across the arch. Now we have antegrade flow across the aortic valve. Looks like there's a bit of AI. Isn't there, Simone?
Yes, a little bit. Let's see.
If you can take it over and tell us what you're seeing.
Now the baby crashed. So there was some effusion, and Fabio used the other needle to drain the pericardial space. I think we sucked some, like 1 to 2 cc's, and then he recovered. Oops. again them in, you see? Let's go. So let's advance that for the sake of time. Yeah. There you go. Oops. I think we gave some epi in the pericardial space. Not sure. I'll get out. Let's see if he recovers. Come on, baby boy. It's getting better. So we gave it into the pericardial space. It didn't work. And Fabio re-entered the left ventricle with a 20 gauge needle. So it's picking up. Hopefully it stays like that. I think we're done here. See, you want to take over and show us some pictures? Fabio did a superb job. Yeah, let's see some more pictures here. Fabio, you are a magician. Kind of stressful here situation.
Give some zoom. And we see here, this is our ascending aorta. This is descending aorta. This is the arch, and there is only anterograde flow here, as we see. I think we have to wait and see what we have tomorrow and the following weeks.
So if we had to do that today, we would have used a larger needle, large bore needle, maybe a 17, which allows you to advance a 4 millimeter catheter. It's from Biotronic in Europe, this balloon catheter, and you can reach up to 4.7, which would have been too much for this kid. And I don't think we don't inject epi intracardiac anymore. So that's what we would do at the moment. So the mom was discharged home the following day with no complications. The fetus was fine. He had a moderate pleural effusion. And we show that this was 3 days after the procedure. Still, the left ventricle was not beating that well. There was some antegrade flow, a little bit of AI. And as one can see here, and this patient subsequently was submitted to a balloon aortic valvuloplasty in the neonatal period, a hybrid, and atrial septostomy. So the balloon was done on day of life 3, hybrid day of life 10, and then atrial septostomy and day of life 16. He had a rocky ICU stay. He stayed there for 40 days, about 50 days in the hospital, but eventually he recovered. And this is what I think it's very interesting in this case. So during infancy, the serial echoes showed improving right ventricular function. As you can see here, the ASD measured about 4 millimeters. There was not much gradient across the aortic valve. There was no AI. There was no gradient across the ductal stent. There was no retrograde aortic artery obstruction. And bilaterally, we observed a gradient of around 50 to 60 millimeters in both PAs. So the mitral valve was about the same size of the tricuspid valve. The LV length was adequate. So this family had the means to go abroad. In fact, this was the first patient that we did a stage rehabilitation of the left ventricle. So at the age of 9 months, this patient was referred to Boston Children's Hospital for possible biventricular repair. So these are the MRI findings. It's courtesy of Dr. Tresky. One can see here the big right ventricle, left ventricle here, very hypertrophied, as one can see here. We're going to see some AI. There's the ASD shunting left to right, and the stenotic aortic valve. We're going to see the bands in a minute. That's the right pulmonary artery, and that's the left pulmonary artery. So some more pictures of MRI. One can see the fibroelastosis here all over the place. There were some calculations of volume. This left ventricle looked fine. And Lisa did the cath. One can see there was not much gradient between LV and ascending aorta. The left end diastolic pressure was fine, and there was no gradient across the stent. There was a bit of a concern about one of the pulmonary veins, the left inferior pulmonary veins, a little bit of stenosis. These are the pictures, the PDA stent, the bands here, nice pictures. And so this is the aspect of the left ventricle after 9 months. So what Pedro de Unido did was to resect the EFE layer. This was the left ventricular overall, and this was the TE after cardiopulmonary bypass. So normal sized left ventricle, the ventricular function was normal. In fact, it was hypercontratile. So this patient was kept under a beta blocker infusion. Pedro left a small SD, which was shunting left to right. Of course, the aortic valve was thinned out and was very mobile with a tiny little gradient across it. So this patient had an eventful course in hospital, is currently living in the northeast of Brazil, asymptomatic on beta blocker with normal systolic and diastolic left ventricular function with a small gradient across the aortic valve. There is no gradient within the PAs, normal right ventricular systolic pressure, and ASD measuring 2 millimeters. So in conclusion, the aortic valvuloplasty in the fetal life may halt the progression to hypoplastic left heart syndrome in selected patients. And a biventricular circulation may be achieved with emphasis placed on the stage rehabilitation of the left ventricle. And neonatal hybrid palliation, at least in our hands, for these cases, works as a bridge for a biventricular repair later in infancy. So thank you.
Thanks, Carlos. That's amazing. Fantastic
Amazing,
work.
Terrific.
Does anybody have any questions or comments from the audience?
It's a very good case. We had a case 2 months ago or 3 months ago. We did fetal intervention, and there was severely impaired left and improved, but we remained with, because it's dysplastic aortic valve, we used size 4 and 17 needle, and then the patient required intervention after delivery. The question that we had at least mild plus AI, and we found it improved with time. So from your experience, there is evidence that the AI, which will develop in utero, it might improve. So you can go with higher balloons, bigger even the annulus, bigger than the annulus.
Yeah, this is a very good comment. In fact, we think that AI is a marker of efficacy. We really want to see AI. If we're doing this case today, probably we would have used a 4.4 millimeter balloon to really open up the valve, and would like to see more AI. And AI in utero is very well tolerated because of low resistance of the placental circulation, high left ventricular and diastolic pressure, and for some reason that we don't know, the tissue heals itself and AI becomes less and less over pregnancy. And most of our patients, when they are born with no AI at all, or a very little amount of AI. Our last patient that we did, we had to do 2 procedures within 2 weeks apart to open up the valve. This was the sole patient that was born with more AI. But believe it or not, over the time of 5 months, this patient has tiny AI. So we really want to see AI as a marker for the efficacy of this procedure.
Thank you very much. Very good case.
Carlos, really outstanding and beautifully illustrated. You used a 3.5 balloon, but at, I can't remember the atmosphere, 16 atmospheres.
14 atmospheres. It went
14.
up to 4.2.
4.2. And then you just alluded to saying you'd use a 4.4 balloon. So what do you mean by that? Do you mean you'd go up even higher, or is there a, say, a 3.75 balloon that goes to 4.4?
No, I mean the 4 millimeter Pedra balloon from Biotronic, it goes through an 18 gauge needle. We used a 17 gauge needle. So we try to put larger things. Now we are more confident, so we are sort of over-dilating the valve a little bit by maybe 20%.
Just technical, I understand the logic, I'm just getting technical details. So you have a 4 millimeter Pedra.
Goes up the way to 4.7.
Goes to 4.7.
14 atmospheres.
Yeah, great.
Yeah, the 3.5 go up to 4.2, 4.3.
And that goes down in 18 an 18 gauge needle.
Needle, exactly,
Yeah.
the 4 millimeter.
Fantastic.
Yeah.
Thank you very much indeed. I think we'll, I don't think we can top that, Carlos. That's been terrific. Oh, one question here.
Of course, I would like to thank the Boston group to allow me to present the pictures here.
It's Miguel.
Hi, Carlos.
Hi, Miguel.
Very nice case. Very interesting and well with the final exit excellent. I want to ask you which are the limits you take for do the procedure?
Which one?
Left ventricular volume, age, and aortic aneurysm.
You mean in the neonatal, in the fetal period?
In the fetal procedure.
Well, you know, there are markers of evolving hypoplastic left heart syndrome in those patients. So it's a composite of many findings. So the left ventricle is dysfunctional, very dilated. You see left to right shunt across the PFO. You see retrograde aortic arch flow. There's no antegrade flow across the aortic valve, and you see a monophasic pattern when you put your Doppler across the mitral valve. So when you come across a patient with critical AS and all these findings, in over 90% of times, these patients develop hypoplastic left heart syndrome. And then this is why we indicate the procedure to halt this progression and trying to achieve a biventricular repair, which is in our hands. A reasonable biventricular repair is better than a good univentricular repair, at least in our hands.
Thank you very much.